morning. It's a real pleasure to be able to present some of this findings. Throughout the meeting, recurrently, we've heard the question of how much does it cost? And I'm happy to be able to present to you some very early, and I really mean very preliminary results from work that we've been done, modeling work that we've been doing with the Imperial College of London to try to answer this question. On the first day, Godfrey presented the strategy which gives us goals through 2030, which are both can be divided into elimination goals for incidence and mortality. So impact, 90% reduction in incidence, 65% reduction in mortality. To meet those impact goals, we have service coverage goals that measure the coverage of the intervention. So the interventions are listed: vaccination and other measures to prevent mother-to-child transmission, safe injection, harm reduction, HPV treatment, and HCV treatment. The point of the presentation is really to try to cost these various interventions and give us a sense of what are the global costs. Before going into it, I think there's several important factors that are specific to hepatitis that influence how we should evaluate these results. The first is the global burden of disease. They're listed there, but going to the first one, hepatitis is primarily, both B and C, is primarily the disease of middle-income countries. If we look at the countries that have the largest number of people with HCV, and this is the top 10, we have 1 low-income country, DR Congo, 2 high-income countries, US and Japan, and the rest are middle-income countries divided between upper and middle. This has 2 important implications. The first is that these countries are not normally the recipients of overseas development assistance, which means that they will be expected to fund the viral hepatitis response with largely with their domestic resources. Certainly that would be true for a country like China. The other important consideration is that since this will have to be funded domestically, the price of the drugs is going to be critical. And these countries that are middle-income countries are sometimes excluded from the voluntary licensing agreements. And therefore, this issue of what the price of the drugs will be in these countries will be a very hot topic for time to come. For hepatitis B, the situation is similar, but first of all, China really dominating it. More than half, as we've heard, more than half of the total number of people, the deaths are from China, and over 75 million people with infection. This is based on the most recent estimates just published last month. Here there is a shift to more lower-income countries, but still the majority of the countries of the top 10 are middle-income countries, with the exception of DR Congo and Ethiopia. The second factor is that although we talk about these interventions as hepatitis interventions, in fact, they are largely health system components. It's the components of a comprehensive health system. So that means injection safety is not just for hepatitis. It covers hepatitis B, C, as well as HIV. Similarly, for blood safety and harm reduction. HBV immunization can be divided. Parts of the costs are covered by the immunization department. Part would be, for the birth dose, could be considered a hepatitis-specific cost. Now, these are very rough categorizations. So really, it's hepatitis B treatment and hepatitis C treatment that are the new additional costs that would really be attributed in large part to hepatitis programs. The third factor is the unknown about price. We know this is a graph showing us what's happened with the prices, a logarithmic scale. So a 100-fold reduction in the first year of the introduction of the first of the DAAs. And then now the generics coming, a big question mark is what will be the trajectory of decline of the generics, and how will they become available in middle-income countries, and how will the price of drugs reduce in high-income countries, as I will mention in a moment. The last important element as a background is that already we are spending a lot of money on hepatitis care. This is the end-stage liver disease for cancer and cirrhosis, as well as a lot of substandard, ineffective treatments. We conducted an analysis with China CDC investment case, and it was estimated that per person, the cost to a patient is $1,600 for a chronic hepatitis and over $6,000 if they have cancer. A lot of the medicines that are given are herbal or other that are of unknown but probably limited utility. So the costs are there. This analysis does not take into consideration sort of cost replacement or cost saving. It'll really be just a cost analysis. Okay, let's turn to the, when we did it in China, there was it was in fact shown that scaling up treatment was cost saving, which is unusual for health intervention, with HBV being 1.3 times dollars saved per expended, and HCV 4 to 5 times. So this is work we'll continue really to show the benefit that you get from the scaling up treatment. Turning now to the model, these are the assumptions. For hepatitis B, infant vaccination, 3 doses was $10, birth dose $100 per child, and treatment with antivirals $80 per year. So the current price for generic tenofovir is about $4 a month, so this includes some additional costs. For hepatitis C, we did take the full cost into consideration in this model, even though, as I mentioned, this is a shared cost across other programs. And the treatment would be, we're assuming a $200 treatment in low-income countries, $500 in middle-income countries, and $10,000 in US dollars in high-income countries. So this will be phased in between now and 2020. So really, it assumes large-scale price reductions, particularly in high-income countries. We don't yet have a complete data on the blood and injection safety components, so we just costed it as $1 million per year for the hepatitis component of those interventions. The model includes, as I mentioned, drug price reductions by 2020, efficiencies in service delivery beyond that through 2030, overhead costs of 14%, no discounting, and we'll present today the low and middle income country cost scenarios, but will not deal with high income countries, really assuming that they will be funding themselves from their health accounts. Overall, the costs, when we costed it, 41% of the cost was in high income countries, and that's a large part the result of the high cost of the antivirals for hepatitis C. But we'll not, so going forward, we're going to look at just at the low and middle income countries. Okay, so here it is, the slide you've been waiting for. So this shows the annual costs between now and 2030, and we've grouped the countries in different ways. The green bar is just the low-income countries. The reddish bar is low and low middle-income countries, and the gray bar is low, lower middle, and upper middle-income countries. So you can see that the costs start, if you look at the gray bars, a little over $2 billion per year, starting next year, and peaks in 2025 at about $11 billion per year. If you look at just at the green bar, in the low-income countries, which usually are, for these sorts of interventions, require overseas development assistance, the cost is less than $4 billion per year. Over time, after the peak, the costs start coming down as the burden of disease is reduced thanks to treatment and thanks to a reduction in incidence. Looking at the components of those costs, we see that at the very bottom we have the injections, the immunization costs, which are very low in blue. But an important component of prevention is harm reduction. And that is an expensive intervention. We know it works, but it does cost, and that remains a considerable cost for prevention, and the biggest cost for treatment. In blue is HCV treatment, and in red is HBV treatment. And as I mentioned before, those costs start coming down as the burden of infection is reduced. Just to put this into perspective, a report from UNAIDS showing what the global response to HIV. So currently, in HIV is about $20 billion being spent per year. About half of that is domestic resources, and half of that is international. So this is not beyond the scope of what's feasible. So in conclusion, really the question is really what are the elements that make this affordable? I think we're assuming reduction in treatment costs, as I mentioned. Middle-income countries and also high-income countries, we'll have to see a lot of reductions. We have to move towards a more effective public health spending, stop spending money on these ineffective treatments, and assume the cost savings from these effective interventions. Also, we have to consider the fact that a lot of these costs are not hepatitis costs, but are health systems costs that need to be implemented in an effective way. And finally, we need innovations and efficiencies over time. We have to move to standardized treatments. We have to devolve treatment to the primary healthcare level, ways of making it cheaper, which has been included in this model. But a lot of assumptions, but realistic assumptions of what can be done to make these affordable. So really, in conclusion, the spirit of the elimination is that the question is not whether hepatitis elimination is affordable, but rather how can we make it affordable. I wanted to acknowledge the work of Tim Hallett and Shivanti Nayagam from Imperial College and Daniel Lobier from the HIV department at WHO. Thank you.